Okay, why don't we get started again? So when we were talking about treatment, as you all learned, it's complex. It's not as easy as treating some infections, and the outcomes are not as good as we would like. So we need something better, and that's what we're going to talk about now. What's coming? So this is entitled Novel Treatments. And when we think about novel treatments, there's different ways we could study drugs. So we can go out and get drugs that have been approved for another reason. We call that repurposed drugs. They're out there. We heard about one, omadacycline. We can write prescriptions for it. It's $13,000 a month, but still it's possible. It's out there. So those are repurposed. So these are some of the ones that are repurposed. We take, and we'll talk about what this means. Dual beta lactam antibiotics. Think that's a type of penicillin. They're out there. We can use them to treat some of our mycobacterial infections. Cycline. Everyone's heard of tetracycline, minocycline, doxy. There are lots of cyclines, and we'll talk about omadacycline. Rifabutin has been around for years. We heard about that from Dr. Griffith. Not going to talk about that. It's kind of still very investigative. Apomycin is a drug like amikacin, but it might be less toxic than amikacin. We have new drugs, things that are literally new. They're novel. There's nothing like them. One's called epetraborole. One's called SPR720. These are in clinical trials right now. So these are in humans. Then we have new formulations. So these are drugs that are out there, like tigecycline. It's an IV drug that we use to treat abscesses. Well, there are studies that are starting. They're looking at inhaled tigecycline. And the same thing with clofazimine. He showed us pictures of the skin tanning that can occur. So people said, well, we can avoid that by giving it inhaled. So there are studies that are now looking at inhaled clofazimine. And then there's some very interesting approaches, which I would call non-antimicrobial agents, like inhaled nitric oxide, which is a gas that you inhale. And we'll talk about that. Inhaled GM-CSF, this is a molecule that's in our body that can be mass produced, and you can inhale it to try to stimulate your immune system to fight NTM. Gallium, which is a metal. And at the end, I'll talk about something that's very interesting and hot now, which is bacteriophages. So this is the pipeline that's happening right now as we speak. When we develop drugs, we start with phase 1 trials, which are small trials looking for the toxicity profile and often trying to figure out the best dose. Then we move to phase 2, which are larger trials, and then eventually phase 3. In this field, when we get to phase 3, mainly we're studying regimens. But in phase 2, it could be monotherapy or also regimens. You can see we have more things happening now in the phase 2, and we hope they'll be successful so that they move to phase 3. And then after phase 3, we hope is FDA approval. But this takes a long time. So, but the fact that we have this many trials in humans, we've never seen anything like this in the field. So let's start with apomycin. So amikacin, we've talked about that, and that there are toxicities like ototoxicity, sometimes renal toxicity, but it's a very active drug. We like to use the drug because it works, but we have to balance the risk and the benefits. So apomycin, it's a new class of aminoglycoside, but it's actually an old drug. It's been used in the veterinary industry for years. So your pets may have received it, but now because of research, it's moved into humans. It appears to be less toxic than other classes of aminoglycosides. And even if you have amikacin resistant, it's not going to be resistant to this. So even with aminoglycoside resistance to what's currently available, this one seems to avoid that type of resistance. It gets into the lung, high levels in the lung. The aminoglycosides have not always done that very well. This one does. And we have some cystic fibrosis mouse model studies that show that this is a very potent drug. If we're going to use these aminoglycosides, we do want to avoid toxicity, ototoxicity. So this is another really amazing thing that's happening. So this is called ORC 13661. It's a new compound, and it protects the hair cells from damage from the aminoglycosides. This study will begin enrolling in August of this year. So we're very close to getting this into a clinical trial. And what happens when someone takes an aminoglycoside, it gets into the hair cell and it damages it and it doesn't function. This drug seems to prevent entry of the aminoglycoside into the hair cell. So basically, when you're getting your infusion or inhalation of an aminoglycoside, you take the drug, they should be taken at the same time. So this will block that hole basically so the aminoglycoside can't get in. So if you look across the top, those are the little hair cells in a mouse. And the one in panel A is the control, so they haven't received any drug. And that's what normal is. And then they gave the mice, it's called gentamicin. It's been around for a long time. It's like amikacin, it's aminoglycoside. And look what it did to those hair cells. Well, that's what it does to our hair cells. And then they gave the gentamicin with this new drug. It completely prevented the damage. It's amazing. Now, if we look at this figure, on the y-axis, it's just the number of hair cells in the mouse. And so the far left, that's the control, though they haven't received anything. So normally in that 75 to 100 count is what we would expect. They gave that gentamicin, and you can see next, wiped out those hair cells. I mean, really dramatic. And then they gave the gentamicin and started giving increasing doses of this new drug. And by the time you got out to 20 to 30 micromolars, it completely prevented damage. So, I mean, this is amazing information. And the fact that it is going into trial in a few months is great for all of our patients on aminoglycosides. Gallium. So gallium has been around for a long, long time, and mainly it's been used in medicine as a diagnostic tool. They're called gallium scans. They could show areas of inflammation. And it turns out that iron is absolutely essential for the growth of mycobacteria. So much so we tell you, don't take extra iron. Don't feed the beast, because the organisms in you, if you give them iron, they will live. We know this from studies in TB. If you prevent iron from getting to the TB, Mycobacterium tuberculosis, they don't survive. But if you give them iron, they become more virulent. So iron is necessary for all mycobacteria. Well, it turns out gallium competes with iron in the body. And when it does that, we hope we can use that to be able to treat patients. And it turns out gallium is FDA approved already in the US to be given for a very specific condition, high calcium in people who have cancers. So it actually is there, we can use it, and therefore we can study it. So this is again, a laboratory study. So on the left is the percent of growth. So in the first bar, this is just the culture media, no drug. So it's 100% growth. And then we start giving gallium. And look at, on the third bar, I mean, from there on, you've wiped out Mycobacterium abscessus. It's gone. I mean, it just killed it. And on the right is a different form of gallium. It turns out that's the one that's available to treat that cancer-related calcemia. It's not as dramatic, but it is significant kill of the organism. So we talked about how hard it is to treat abscessus. Gallium in this experiment was very, very potent in being able to do that. This is now in a clinical trial in cystic fibrosis patients in the US. We're part of the trial, so it's in humans. This is the first step to see if we can see benefit. Of course, first we're looking at safety, but gallium has been given in other circumstances, so we don't think that's going to be an issue. Epetraborole. Boron. Boron is a molecule that we don't see in antibiotics very often, so it's pretty novel. And what this thing does is it inhibits the ability of the bacteria to produce protein. And you can't live without producing protein. So it's a good approach. And it's active against MAC and abscesses. Not all our drugs get them both. Some get MAC, some get abscesses. This gets both. This is an experiment to show how powerful this has been. This is in a mouse model. And so when we do studies in mice, what we do is unfortunately sacrifice them after they get the treatment. And then you count the colonies in their spleen, or you count the colonies of infection in their lung. So on the left of the y-axis, that's what that scale is. They're just counting how much was in the mouse. So the black bar is the control. So if it's above the line, that means it's growing. And so it's not getting treated with anything, so it's just naturally growing. The next one is we're giving standard of care. What is that for MAC? Azithromycin, rifampin, and ethambutol. And it is now below the bar, so it's killing the bacteria. We're seeing less infectious spots in the lung. And then the next one is when they take the standard of care, those 3 drugs, and they add epetraborole. They just add the drug to the regimen, and it is dramatically killing this organism. And then they just gave it the epetraborole by itself, and by itself, it's better than clarithromycin. What did I say was the best drug we have for MAC? Clarithromycin, azithromycin. This in this model was better, significantly better. So it's a very powerful compound for MAC. And those are the areas where you can see the benefit. So my laboratory tested this against abscesses. So most of the information was about MAC. So we said, well, what about abscesses? So we got about 150 isolates of abscesses, and we tested it with this epetraborole, and we found it was very active against abscesses. So what you see here are the number of isolates and how susceptible or resistant. So as you go to the left, the smaller that number, the more active it is. So if I was to put 15 other abscesses drugs up here, this is the most active. Of the drugs that we use today, of the drugs that our laboratory tests, this was the most active drug against abscesses. So active against MAC and really active against abscesses. Now, this is in a phase 2 trial right now. And unfortunately, it was put on hold. We're waiting to hear why for the MAC trial. So I don't know why, because in the laboratory, it is gangbusters. Cycline. So we've talked about omadacycline. So tigecycline is an intravenous drug that's been around for years. We use it in hospitals when people are very sick, sometimes with pneumonia. But it makes everybody sick. I say it's the most pukogenic drug that I know of. 30 to 50% of people get nausea and vomiting when they get IV tigecycline at the dose that it's labeled for. You're not going to like me very long if that happens to you. But omadacycline is a newer cycline. It is FDA approved, but for pneumonia and skin infection. So this would be off-label use. What we like about it is, well, tigecycline is only IV. Omada comes in oral and IV. And remember what I said earlier, with abscesses, we don't have many oral drugs. So this would be a big addition. In clinical trials, they've compared them head-to-head in randomized trials, and they show that nausea, vomiting is 15 to 8% in those who get IV, 25 to 12, but that's more than half of what we see with tigecycline. So then the issue is it as good as tigecycline? It's definitely better tolerated. We have an oral form. Again, so my lab, we took almost 280 strains. We did the same experiment. So the number of isolates on the left and going from left to right, increasing resistance. It is very active against abscesses. And if the numbers, this 0.25, 0.12, this is one of the most active drugs that we know for Mycobacterium abscessus. So the one before epetraborole, oral drug, omadacycline, oral drug. You can see how this could, if we get these through drug development, through phase 2, 3 trials, we're starting to be able to build a powerful oral regimen. We have to get there. We're not there yet. SPR 720. So SPR 720, people, you know, ciprofloxacin, these moxifloxacin, those are called quinolones or fluoroquinolones. This works the same way. It inhibits an enzyme, but it's not a fluoroquinolone. That's important because that means it's novel. So if you had an isolate that was resistant to the fluoroquinolones, it wouldn't be resistant to this. And in your body, it actually, we change the molecule and make it active. Until it's in our body, it's not active. It has to be activated. And in lots of different ways of measuring activity, it looks like it's really good for the slow growers. What are those? MAC, and one I haven't talked about, Kanzasii. And it's also oral. So now we're getting somewhere, but not as active for abscessus. This is one study, there are several, that's looking at the activity. So on the left are the different species, the number of people in each group, and then that is called MIC range. So MIC means minimal inhibitory concentration. It's the minimal amount that will inhibit the growth of the organism. So on those others I was showing you, as you went left, that number was getting smaller. That meant more activity. So the smaller the number, the better. These numbers in this field, those are small numbers, meaning that's activity. And one, if we look at Kanzasii, that is probably the most active drug we have today for Kanzasii. Kanzasii is the one that we can treat 100% cure rate. I told you I love Kanzasii, but I would love to be able to shorten that duration from 12 months to something shorter and still achieve 100% cure. Maybe this is a drug that will allow us to do that, but it's also good for MAC. This is in a phase 2 trial right now in the US. So it's already moving along through that pipeline, trying to get to you, trying to get to my patients. Okay, beta-lactam. Now, beta-lactams are one of the oldest antibiotics. They're penicillins. And they're things like penicillins called cephalosporins, and another class called carbapenems. This class of antibiotics can be inhibited by an enzyme. It breaks it down so that it doesn't work anymore. And that's called a beta-lactamase enzyme. And there's one in abscessus. Not all bacteria have them. Not all mycobacteria have them. This is BLA-MAB. And if you inhibit that, it's been shown, and there's a drug that's called avibactam. It makes the beta-lactam much more effective. But it turns out if you just give 2 of the same kind of drugs, now this is something we told people not to do for decades. Don't do this. Now we find out if you do it, it provides synergistic activity. And I don't know if you know that term. So it's more than additive, multiplicative. So in microbiology terms, that is what we're looking for. This is an example of a study we did with collaborators in Cleveland at Case Western. And it turns out when you put 2 beta-lactams together, in this case, imipenem's been around for years. If you go into a hospital, you have a certain kind of pneumonia, they're going to give you imipenem. Ceftaroline's not been around as long, but it's an antibiotic also that we use to treat infections. If you put these 2 together, we see synergy. So if we go to the right, remember those numbers, if we could go from low, which is very susceptible, to high, which is resistant. So ceftaroline, resistant, doesn't work. If you give it by itself, it doesn't do anything. And then we go to the left, and there's that imipenem. If you come to someone in the US with abscessus, they're going to put you on imipenem. That is our go-to drug. And we can see that it's more susceptible than ceftaroline because it's moving to the left, to the lower MICs. But if we go to the real left, that's a combination of those 2 drugs. And now that is really active, as we've seen with our drugs. And then if you try to inhibit that enzyme, it actually doesn't add very much. So really just giving 2 of these drugs that I can write a prescription for tomorrow is very active. So we are using this now to treat our patients. This was one of my patients, probably the first one. I'm sure she was the first one. 79-year-old woman. She had TB a long time ago, had some lung resections a long time ago, but now she's got abscessus, unfortunately. So I started her on a typical thing, imipenem. That's what we start. Amikacin, that's what we start. Clofazimine is an, is an oral drug. And I wrote prescriptions trying to get some others that were going to be hard to get because of their cost. 2 months later, she came to me and she's like, I can't keep driving. I'm 80 years old, driving back and forth twice a day to the infusion center. She goes, I need a break. So I said, okay, let's switch you to inhaled amikacin. We'll continue the clofazimine, and I'm still trying to get another drug. But over the next few months, she got sick again. So I had to restart the same regimen. Now, on the right is her initial CT. Let me point, there's a cavity right there, 2 small cavities and some bronchiectasis. And after the several months of treatment, the cavity is still there, a little bit smaller. Those are closed. But more importantly, she was sick. She couldn't gain weight. She was having low-grade fevers, night sweats. Her C-reactive protein was elevated. Her protein that I talked about earlier, that's a predictor for progression, it was very low, albumin. So I started the ceftaroline. So that's that other drug. So I'm combining imipenem and ceftaroline. She did something that I didn't think was going to ever happen. She closed the cavity. She gained 5 kilograms. She normalized her CRP. She normalized her albumin. She became culture negative for the first time. I see her every 3 months, 4 years. She hasn't grown abscessus again. So this was a shocker to me. And it's why we became very interested in this and why we're clinically using it more and more, as are other centers. So we're very excited, but it still needs study. So this is an example of how many combinations have been studied of all the different beta-lactam drugs and the inhibitor drugs. Green is synergy. That's what we're looking for. You put them together, they're better than either one alone. And I put a checkbox there because for the colorblind people, I'm colorblind. I couldn't tell the green from the orange if you put a gun to my head. So I had my administrative assistant help me figure out which ones were green. And she put the checks in for me. Orange is additive. I mean, that's not bad, but we'll take that. But you can see the point is, as we learn more and more, we are going to have these cocktails that we're going to be able to use to treat abscesses better than we have been treating it. And this is imminent. Okay, now let's get to those unusual things. Nitric oxide. So this is a gas. It's colorless, but it's also a molecule that we use in our immune system to kill pathogens. It's in your T cells. It's in macrophages. We have to have it. So what would happen if we gave you more of it? You know, would that help you? Would it kill? It turns out nitric oxide kills everything, including us, if you get too much. That's why you do research to figure out the dose and the safe way to do it. So that has been done. It's already, again, in human trials. Patrick Flume at Medical University of South Carolina and Kevin Winthrop in Oregon did a small study. These were patients with NTM lung disease, both MAC and abscessus, 10 patients, and they treated them. So what they do is they have them inhale this gas for 50 minutes, 3 times a day, 5 days a week. And then the total was 15 treatment days. So first, this is a very short treatment study. You know, this isn't going to cure anyone. We're looking for, is it safe and does it help? And 40% of the patients converted by 3 weeks. So that's a pretty big jump in that short time. Now, when they stopped the treatment, they became positive again. But it was too short a treatment to cure somebody. But it showed that there was activity by just inhaling this gas. This is now being the company that does this, they have a little desktop model, so you can do it at home. The initial studies, you had to be hospitalized, but now it's just a little desktop model and you put on the mask and you can do it at home. So we're excited to see how far this will go, and it was well tolerated. Now let's talk about how do we get your immune system to work better. Everything I've talked about is killing the organism, but can we make your immune system work better? So GM-CSF is a molecule in your cells. It is part of your innate immune response when you get infected with something. We have to have it. It has many functions, but one of which is to fight infection. It's already a human trial. So a couple of trials. So this is one published by a friend and colleague, Rachel Thompson in Australia, 32 patients. Most of them had MAC. Few of them had abscesses. Half were on therapy, half were not on therapy. They inhaled 300 micrograms a day over 48 weeks. So this is a longer study than I was showing you with the nitric oxide. And this was a hard to treat population because they were prolonged culture positivity. 25% achieved culture conversion. Most of them were the MAC patients. So they didn't see as much activity in the abscesses. They didn't have many abscesses. And then they had another of 4 patients with MAC who didn't convert, but their smears, meaning our ability to see the organism, decreased. And so that's also positive. They didn't show any improvement in the clinical things that they were measuring, but it's such a small study. And really was well tolerated. The side effects were basically pulmonary exacerbations from something, like their Pseudomonas or something else. And this is a study, Jerry Nick, who runs our adult program, CF program here. He hasn't published this yet, but this was done here in the US. The National Jewish was one. These were CF patients, 14 CF patients. They were in 3 different groups. Probably the one I'll highlight is group 3. These are people who didn't meet ATS criteria. So that means they just had one positive culture. So this isn't a group that we would treat. But it would be interesting to know if people grew at once, and if we could hit it hard before it got established, maybe that would be a good approach someday. Knock it out before it causes a problem. And they use the same dose, same 48 weeks, 50% converted in this as opposed to 25% in the other. But it was 75% in the small group 3. So if you just grew it once, only one of them of the 4 grew it again. Now, it's too small to be definitive, but there was conversion across all the groups, 43% in group 1, which were the treatment failures. So inhaling this in 2 human trials looks like there is a microbiologic signal, and it just needs to move forward to larger trials. I'll end with bacteriophage. So a bacteriophage is a virus that infects bacteria. They're the most abundant, we believe, organism on Earth. They're very old organisms. Their genome is small. And there were anecdotal reports of people who were dying from resistant bacteria who got treated with phage who survived. And this made people very interested in this field. And the first one that was presented that had mycobacteria was a 15-year-old girl with cystic fibrosis who post-transplant, lung transplant, developed disseminated Mycobacterium abscessus. And so these are some of the scans looking at before and after treatment with a phage that she got. And so in the CT scan there, she had these masses, those got smaller. This is a PET scanning, and there were lesions here that all, the 1 and 2, that either got smaller or even resolved. She had skin lesions that were disappearing. So it was clearly having an impact on her. And this got everyone's attention in the mycobacterial field. Well, shoot, can we use this in other patients? So we did, because we had a local patient, a 26-year-old man. He had chronic infections like Pseudomonas. He actually had MAC 5 years earlier, and he was cured of the MAC. But now he has abscesses, And despite 4 or 5 drugs for 4 years, we could not get him to become culture negative. And this was in the background as his function was declining and he needed a transplant. And they won't transplant you if you have an active abscessus. Very difficult, which means if a CF patient, any patient gets abscessus and they need a transplant, it's almost a death sentence. So we said, this is the guy we should try phage in. You know, there's really only upside to this. So he got a phage. He was treated for a year. The phage treatment is intravenous usually, twice a day, easier than an infusion because it's a push, and he does it at home. And let's see what happened to him. So this is complex. So you're gonna follow me. We're starting at the top. A, all those little red lines are positive cultures for abscessus. So for over a year, I mean, he's got just lots of positive cultures. Now, B are the negative cultures, so intermittently negative cultures. This line that you see going down, that's his lung function. And he has now gotten to the point he needs a transplant or he will not live. All of the drugs, this is his regimen. Every drug that I mentioned to you this morning, he got. And we could not get his cultures negative, which meant he was not going to get a transplant. So he got phage at this point. Now look to the right in terms of the red hashes up there. They disappeared. His cultures became negative. He got transplanted. What does that mean? We got his lungs. And there was no abscessus in those lungs. He unfortunately died 2 years later, not from abscessus, from rejection. But we got his lungs. No abscessus. I mean, we eradicated abscessus in him. And we think that was the phage. So soon after this, well, yes, and this is just to show you kind of the clinical. If we look at the top CT scan, there's a cavity and it went away. And then in panel B, there was a nodule, it went away. C, there was a nodule, went away. D, it got a little bigger, then went away. So we were seeing this before our eyes that he was getting better. And this is just some experiments that we were doing, Jerry Nick, looking at things like, could we detect the abscessus in the sputum with DNA? There's a certain molecule that's in the wall of the mycobacterium. We can measure it in the urine. So we were looking to see if it was going away, and antibodies. And if we go from left to right, everything got better, showing that this thing was killing the organism. So soon after that, there were 20 patients published. We work with Dr. Graham Hatfield at the University of Pennsylvania, Pittsburgh. He has the largest library. So when we have a patient we want to start on phage, we send the isolate to him. He screens and tries to find a phage. 200 patient isolates were sent, but he didn't find phage for everyone. So it's not a panacea yet. But the results were generally favorable in at least half. Unfortunately, some people develop an antibody to the phage. It's foreign, right? So it sees it and it kills it. And it probably before the phage can do what it wants to do. So we have more to learn. How do we prevent that from happening so that more people will respond? But it's kind of very exciting area. These are the trials. This is my last slide just to let you just know that there's stuff happening for you. These are trials that are happening, phase 1 to phase 3. Some of them are regimen trials looking at 2 versus 3 drugs. Some of them are looking at novel compounds, but we hope this will only grow. And it's the most exciting time, I think, in the field for all of us. So I'll stop there. Thank you. Question? Coming.
How quick was the response to the bacteriophage?
It took many months before it converted. Yeah, it was a slow response. And I forgot to mention, all of these patients also were treated with antibiotics. If you look at the phage under an electron microscope, you can see the wall of the phage like being torn apart. So we think it's allowing the antibiotics to get in better. So we think you should have both, not just one. And theoretically you can get resistance to a phage. So we try to give more than one, but sometimes Dr. Hatfield can't find more than one. And just also know there are other companies that are emerging that are phage companies, and they're looking for phage for MAC, abscesses. So I think this is going to grow. Yes.
It looks like imipenem and meropenem, they're in the same class.
Yes.
How is the imipenem how's that introduced into the body? Is that an infusion or pill or?
IV. So it's only intravenous. Imipenem is only, same with meropenem. They're
No.
both intravenous.
With the meropenem, I'm on that. I use that as a nebulizer. So that's why I was
Okay.
wondering
Yeah.
if that's something that's been looked at before. I do that twice a day, meropenem.
Yeah. Meropenem went through that chart where there are all the combinations, but meropenem has been studied as well within this dual beta lactam strategy, and it behaves like imipenem. It's synergistic.
So that's another option instead of infusion only.
Yeah.
I also just wanted to comment about phage therapy. So just to level set, the process takes months.
Oh, yes, please. Yeah.
Yeah, so it takes months to screen for a phage. It doesn't work perfectly. And then the whole process to kind of get through to the infusion just takes a really long time just to kind of set expectations. And then please don't email the Hatfield Lab on your own. They're pretty busy.
Yeah.
Please just talk to your provider if you think that might be right for you.
Yeah. It's research now.
Yeah.
And it's research is slow.
I don't know. who this was.
When you say gallium and boron, they're not pure molecules, or, I mean, atoms, they're in some kind of compound, right?
They're what?
They're in some sort of compound.
Yeah, the molecule has the epetraborole is a molecule and it has a boron molecule within it.
But
Gallium is a pure metal.
Oh, it is.
Yeah.
So how do you know what boron compound is going to be optimum for?
Oh, well, that's a interesting question, because now there are these high throughput screening methods where you can screen millions of compounds. And so that's how these are all discovered, through these screening programs. And they take what are called the best hits. And so there are other boron compounds that exist. But in a process years ago, actually, with epetraborole, it was very active. Now there's another one being studied, different company, and it's being studied in tuberculosis. But it's also a boron molecule or compound with a boron molecule. Yes, go ahead.
I had read The Perfect Predator several years
Yes,
ago
Yes.
and found it to be a very exciting read. It reads like a mystery novel. But the final note that she left you on hanging, the
Yeah.
cliffhanger was, realistically, how far into the future will we routinely see that kind of therapy? Where you just send off, a sample of your DNA or whatever it is, and then you get a response and you're off and running.
Yeah, so that was one of the early phage stories. It was her husband who was sick and got phage and survived. So there are trials now using phage therapy with Pseudomonas. They're happening right now in the US. So it's not just mycobacteria that you can treat. So I would say the Pseudomonas trials are further ahead because it's companies with money, able to do it as opposed to academicians doing it. Those trials, I mean, if they work, you'll have phage therapy probably in a couple of years for Pseudomonas. We're behind because we grow slowly in the mycobacteria. But no, we're very excited that this is going to go somewhere. Maybe last question. Yeah.
I think it was in the global forum, there was someone that had a link to a blood test that they are using to identify MAC, I think, for AIDS patients. Can you comment on that?
As a diagnostic. Yeah.
as a diagnostic.
Yeah, so there are some very interesting diagnostics in play right now that one of which can detect RNA or DNA, similar to DNA in the blood for mycobacteria. That could be used for diagnostics. It could also be used for treatment response. You know, if I put you on treatment, is that going down? If it's not going down, then you're not responding to treatment, possibly. So there are several different groups working on that. One is Tony Hugh, who we are collaborating with on one of these tests. But there are others, and there's a company that we're working with that has developed a way to do drug susceptibility testing in an hour. So, I mean, you know, we've been talking a lot about treatment, but diagnostics is changing too. Yeah. Okay, I'll introduce. Yeah. Okay.